Good afternoon, everyone. Good afternoon, Dr. Ahmed, Mr. Bharadwaj. Thank you for joining us on this essential webinar on diagnosis of dengue fever. It will be presented by a distinguished Dr. ShariqAhmed from AMU. Dr. Ahmed, with his extensive research in virology and infectious diseases, will guide us through the complexities of dengue fever diagnosis. As dengue continues to pose a significant global health challenge, accurate and early detection is crucial. Dr. Ahmed's insights will benefit clinicians, researchers, and public health professionals. This webinar is set to enhance your understanding of dengue's clinical presentations and the latest diagnostic methodologies. Thank you once again for being here with us today, as I hand over the baton to Dr. ShariqAhmed to take us through this dengue fever, a recurring public health problem. Over to you, sir.
Thank you so much for introduction. So since we have a plethora of diverse attendees, I would like to discuss dengue with various aspects of it. So we will begin with dengue fever. So dengue fever comprises of a viral hemorrhagic fever, which includes there is viral vascular damage and there is symptomatic bleeding. These viral hemorrhagic fevers belong to three distinct groups like arboviruses, filoviruses, and rodentviruses. Dengue fever comprises in the arboviruses. There are filoviruses like Ebola and Marburg, and there are rodent-borne viruses like hantaviruses that cause viral hemorrhagic fevers. So basically, we will study about the arboviruses, which includes the dengue fever. So arboviruses, then there are arboviruses that are also many like dengue fever, chikungunya, yellow, and Zika virus. Today we will be studying about the dengue virus, which belong to the family Firoviridae. So the arboviruses are a diverse group of RNA viruses transmitted by blood-sucking arthropods. They are the insect vectors which transmitted the virus to the vertebrate host. They multiply inside the insects and establish a lifelong harmless infection in them. The viruses that are transmitted mechanically by these insects are not included in the arboviruses. So arboviruses are further divided into 5 families like toga viruses, which include chikungunya virus. Then there is flaviviridae, which include Japanese bee encephalitis, dengue, yellow fever, and Zika that we commonly know. There are numerous other viruses like St. Louis, West Nile, which we will not be studying today. Then there is Bunyaviridae family, Rheophyridae, and the Rhabdoviridae. So this was the brief introduction about the arboviruses, that in which the dengue virus comes under the flaviviruses family. So what is dengue? Dengue is a most common arbovirus found in India. It is a spherical 40 to 60 nanometer in diameter virus particle, and the genome is made up of enveloped virus with a positive sense single-stranded RNA, which is 11 kilobase pair in size. Dengue comes from a Swahili word called as denga, which means fastidious and careful. And these dengue viruses are divided into 4 serotypes. Basically, till 2013, there were 4 serotypes infecting the humans, like DEN1, DEN2, DEN3, and DEN4. But now a 5th serotype has also been discovered, which is known as DEN5. It was detected from a 37-year-old farmer that was admitted in Malaysia in 2007. And the 5th strain, after the extensive study, it was in October 2013. It was renamed as a 5th serotype of dengue virus, which was separate from DEN4. So now they are circulating 5 serotypes of the virus: DEN1, DEN2, DEN3, DEN5. This serotyping is very important because Due to these serotypes, there are various problems that recur in the dengue disease that I will discuss further. Further, the virus particles, mature virus particle contains three structural proteins. One is known as capsid, denoted by C, then is precursor M membrane or precursor M membrane protein, or the envelope E. And it is covered by a membrane host-derived membrane bilayer and a single copy of positive single-stranded RNA genome. It is important to study these viral structure proteins because human antibodies against this virus is targeting mainly the envelope and the precursor membrane M protein. So this is a pictorial diagram of genome of the virus. You can see this orange color parts are the structure of the virus, which includes C, PRM, and E. And these blue color parts are the non-structure virus known as NS1, NS2, NS3, NS5, NS2A, etc. In this, NS1 antigen is very important, which help in the diagnosis of the virus as it is secreted in the blood or serum during the viral infection. All flaviviruses, including dengue, have the similar life cycle. They infect or attach the cell wall. Then there is fusion, there is disassembly, and there is protein translation. Then in the Golgi apparatus and the endoplasmic reticulum, maturation of the virus takes place. They form a virus particle. Then it takes the cell membrane of the virus to form the virus particles. So the dengue virus is formed the host cell membrane, and there are structural proteins and the non-structural proteins and the positive single-stranded RNA. Now, as we know, it was an arbovirus. Dengue is an arboviral disease, so it is transmitted by a vector. Vector in this disease is mosquito. So Aedes is there are three types of mosquito like Aedes, Culex, and other. So Aedes is the vector of dengue viruses. And among the Aedes, there are two major varieties like Aedes aegypti is the principal vectors and Aedes albopictus is the secondary vector. There are numerous other species like Pollinienses, Herbidius, Cookie, Rotium, etc. that occurs in different regions of the world. So these Aedes mosquito bite during the daytime, and the Aedes aegypti is known as a nervous feeder. Means it does not take it to full blood meal in a single bite. It bites multiply and therefore is a most efficient transmission vector for the transmission of dengue virus. We can identify this dengue virus by these presence of bands on the leg and thorax of the mosquito. So white bands and scale patterns on the leg and thorax of the mosquito, we can identify this Aedes aegypti mosquito. Second vector is the albopictus. It is also known as Asian tiger mosquito. It is less efficient transfer because it takes the full meal in a single bite. So it does not bite different or does the multiple bites of a single human. So it is less efficient in and a very aggressive feed. These two mosquitoes are the major transmitter vectors of the dengue virus. So what are the features of these Aedes? They do usually breed in stagnant water. And so they don't breed in the moving water, and which is usually dark and shaded places, outdoor or indoor. So usually the water is clean and collected water, like rainy water, which collects in the ponds and stagnant water. They breed in there. They are also cannot fly a very long distance. So they remain near the houses. So the distance of flight is 100 meters. And they are most active 2 hours before the sunset and in the morning. They are also known as therefore day biters. So these are all the places where these mosquito larvae bleed. We should check these places and does not let water accumulate in these conditions. Now coming on to the transmission cycle. As I told earlier, there are 4 serotypes: Den1, Den2, Den4, and the recently Den5. So the first 4 maintains a human mosquito cycle, while the Den5 is still maintaining a sylvatic cycle, and there is an occasional spillover to the humans. Then how does this mosquito get the infection? So a patient having dengue, it bites and sucks the blood from that person, and the virus multiplies for about 8 to 10 days in that mosquito. It does not transmit the virus to the humans, but in that 8 to 10 days period. That is known as extrinsic incubation period. So when the virus matures in the mosquito, then after 8 to 10 days, when the mosquito again bites another person, then it sends that virus in the blood of that next person, and the person gets infected. So this is known as the human mosquito cycle. An Aedes mosquito can also pass this dengue virus to their offspring. That is known as transovarial transmission. So if in between this infected mosquito, if it gives birth to another mosquito, then there is a transovarial transmission. So that intrinsic incubation period and the extrinsic incubation period. So duration between mosquito feeds on a human infected with dengue and it can transmit to other person is known as extrinsic incubation period. And when when the humans get infected by the mosquito bite and till the viremia develops, it is known as, or the signs or symptoms develops, it is known as intrinsic incubation period. Now coming on to the geographical distribution. As we all know, dengue is very prevalent in the Southeast Asian region and the Africa region. Although many countries has been infected. There are more than 100 countries in which dengue has become endemic nowadays. And more than 3.9 billion people are at risk. WHO has given this estimate from a study that about 3.9 billion people are at risk of this dengue disease every year from now. And as we can see from the numbers, from 0.5 million or 5 lakh cases in 2000, the cases have risen to 5.2 million in 2019. So we can see there is a 20-fold rise in the case in 20 years. And we can see there's 390 million viral infections occur every year, among which 96 million manifest clinically. And from these 5 lakh cases of dengue hemorrhagic fever occur every year. Mostly these are children. This is the graph shown by, or a global map by CDC, which shows that India comes under the frequent and the continuous dengue risk. So there is every year we have a dengue epidemic mostly in our country because it has very favorable condition for the mosquito. And the more affected countries of India are the regions, this Haryana and Rajasthan belt, then Gujarat, then UP some areas, then the southeastern part, and this Hyderabad has Telangana, and that region has very high percentage of dengue infections. All 4 serotypes are found in India, but Den5 has not been recovered from India till yet. This is a chart given by Ministry of Health and Welfare showing the dengue cases. This is only, we can say, a tip, because in India most of the cases of dengue are subclinical and are not reported. These are only the reported cases. So we can see that the problem is very high. And we can see that 2019, there were 15 lakh cases. Then it subsided a little in 2020, or maybe it may be due to COVID. The reporting was less. Then it again started to increase. In 2021, there was 19 lakh cases. In 2022, there were 23 lakh cases. And till now, till September, there were 9 lakh cases, about 9.5 lakh cases till now, and 91 deaths have occurred. So we can see that dengue has become a major health problem in the country in the recent days. Now, what are the factors responsible for these increase in incidence? So it is very complex and a coordinated manner. We can say that because it is not fully understood. So the factors that have led to these increased incidence, it may be due to demographic and societal changes, which is the major contributor. Then there is unprecedented global population growth. The population has increased. Then the planned and the unplanned urbanization has led to these dengue increase. There is the housing has been substandard. There is crowding, deterioration of water, sewer and waste management, unplanned urbanization, lack of effective mosquito control measures. These are all led to the increase in. And one of the major factor is that we have still relied, although there are biological controls and all are available, in our country, we still rely on the space spraying of the insecticide, which has not been effective and which has given a false sense of security, because the dengue mosquito population decreases for some amount of time, but it all only gives a false sense of security to the government and the community. Then uh, the Aedes aegypti has become more resistant to these DDT and all, and its population have increased. Then the domestic breeding places have increased. There is unsanitary discard of the non-biodegradable plastic, which allows the collection of water and the use automobile tires. Then another important is the increased air travel. Now the infection and the disease or the mosquito can travel from one region to another region on plane and it had led to the increase of the dengue infection. Lastly, budget cut in public health sector and lack and challenges in the development of effective vaccine practical. Many vaccines are in guidelines, but there have been no effective vaccine except one till now, which is also in phase 4 trial, but not available in India. So after this, the problem we have seen the problem statement of dengue. We should know what is the pathogenesis of dengue. So the dengue, there are two type of infection. One is the primary dengue, when we get infected for the first time. Then there is a secondary dengue, when another serotype, we get infected by another serotypes, the second type, and it causes a more severe diseases. So we should know about the antibody response of our body towards this. So there are two type of antibodies produced. One is the neutralizing antibody and one is the non-neutralizing antibody. These neutralizing antibody, suppose we get infected by DEN1 virus. So neutralizing antibodies, these are formed against the DEN1 virus. And this will be protective for a long time. They may last for a lifelong also. Then this is the menace, which is a non-neutralizing antibodies. So if suppose we get infected by the DEN1 serotype, and the neutralizing antibodies are developed against that DEN1 serotype, it will protect us against the infection, primary dengue infection, and we will remain immune for the DEN1 serotype by dengue virus lifelong. But we get infected second time by the DEN2 virus. And these non-neutralizing antibodies that are formed against the first DEN1 infections, they are not protective in nature. But instead of neutralizing the second serotype, it protects it from the host of the immune system by inhibiting the bystander B cell activation against the second serotype. This phenomena is known as antibody-dependent enhancement. So what is basically this antibody-dependent enhancement? So these non-neutralizing antibodies, which are formed when we were infected by the serotype 1, DEN1 infection, they were formed against the DEN2, DEN3, DEN4. So when we get infection the second time, supposedly by DEN3, DEN4, DEN2, these antibodies, instead of protecting, they will save these virus from the bystander B cells, and there will be a cytokine release and there will be a severe dengue disease due to these antibodies that will protect the virus instead of killing the virus. So these non-neutralizing antibodies promote the recruitment of the mononuclear cells and will help then releases the cytokine. So this phenomena majorly it is seen when after serotype 1 infection we are infected by serotype 2. Although it can occur in any combination, but the most severe form of infection can occur when serotype 1 we get infection by serotype 1 and followed by serotype 2. Now coming on to I am talking about the severe dengue and classical dengue and dengue fever. So what are these? So WHO gave the classification in 1997. They classified dengue into 3 clinical stages: dengue fever, dengue hemorrhagic fever, and dengue shock syndrome. So what was dengue fever? Dengue fever is acute febrile illness for 2 to 7 days duration, and it manifests like headache, retroorbital pain, myalgia, arthalgia, rash, and hemorrhagic manifestations. So after this clinical phase, a person may develop, a person may resolve by on itself by some supportive treatment like fluids and all, or the body can react in another way, and like if secondary dengue is there, then it can lead to dengue hemorrhagic fever. So what is dengue hemorrhagic fever? So it is up on the above of the dengue fever, there will be hemorrhagic tendencies. There will be a positive tourniquet test. There will be petechiae, ecchymosis, purpura, and there will be bleeding from the mucosa, gastrointestinal tract, and from other sites. Plus, there will be thrombocytopenia. There less than 1 lakh per cubic millimeter. There will be platelet count. There will be decreased platelet count, and there will be plasma leakage. There will be evidence of plasma leakage by increased vascular permeability. Also, there can be also increase in the hematocrit rise and 20% drop in the hematocrit followed by the volume displacement and signs of plasma leakage, which can be seen by edema, pleural effusion, ascites, and hypoproteinemia. Then, if the condition further worsens, then it can lead to dengue shock syndrome. What is dengue shock syndrome? After the hemorrhagic manifestations, there is very rapid and weak pulse, and there is narrow pulse pressure of less than 20 mmHg, or hypotension for the age, and there is cold and clammy skin and restlessness. When this occurs, we say it dengue shock syndrome. But now the WHO has given another classification in 2009. It has classified dengue into dengue and severe dengue. Dengue can be with or without warning signs, and there are severe dengue. Severe dengue it is called when there is severe plasma leakage, there is severe hemorrhage, or severe organ impairment. So what is dengue without warning signs? There can be a probable dengue or a laboratory confirmed dengue. Laboratory confirmed dengue is when we have a laboratory confirmed report for the dengue, or when we have only clinical signs. Probable dengue is when we have clinical signs or we have a rapid test positive, like nausea, vomiting, fever, aches and pain, rashes, tourniquet positive, and the leukopenia. Warning signs. What are the warning signs which we should see, and we should admit the patient immediately after if we are seeing the warning sign. Without the warning sign, patient can be managed at home with antipyretics like paracetamol and the oral fluids. But after warning sign developed, we should consult a doctor and immediately hospitalize the patient. Warning signs are abdominal pain and tenderness, persistent vomiting, clinical fluid accumulation, mucosal bleed, lethargy, restlessness, liver enlargement, and other. Now, what are the criteria of severe dengue? In severe dengue, there is severe plasma leakage, which can lead to shock, or fluid accumulation in the respiratory or in the lungs, which can lead to respiratory distress. There can be severe bleeding, leading to hemodynamic instability, and there can be organ failure, which can be detected by raised AST and ALT levels or impaired consciousness, or it can also affect heart and other organs. So this is the new guidelines of WHO, new classification of WHO based on the severity of dengue. This is the comparison of the two. So these clinical features which are discussed, which define the dengue fever, they have some specific features like the clinical disease, if it does not proceed to dengue hemorrhagic fever or to dengue shock syndrome, in 4 to 7 days, it get treated by itself by the body. And there are the features which occur in dengue. There some of the important points I wanted to tell you, that fever, it is of very high grade and saddleback. Saddleback mean form. It has two peaking. It may subside after third day and rise again after on the 5 to 8 days. And there is a very deep myalgia and bone pain. So it is also known as break bone fever. And there can also occur rashes on the third and the fourth day. Although it is rarely seen in Indian people, mostly rashes are seen in the Western or the white people. Now, if it proceeds to dengue hemorrhagic fever, then there are three pathophysiological phases. First is the fever stage, which lasts to 2 to 7 days, which is the hallmark of the dengue. Then it progress into plasma leak, which for 24 to 48 hours, there is plasma leakage. There is normal to subnormal temperature, various degrees of plasma also lead to shock and death. Then if the patient started to recover, there is the reabsorption phase. It lasts 2 to 4 days, and there is resolution of the plasma leakage and hemorrhage subsides. There is stabilization and the platelet count starts to increase. So the whole dengue hemorrhagic fever, if it is managed properly, then it goes through these three stages. Like there is febrile stage, then the critical plasma leak stage, and then the convalescence or the reabsorption stage. This is the sum of the sign and symptoms of dengue hemorrhagic fever, like rashes, intravitreal hemorrhages, chymosis, and gum bleeding. Now, before going on to the laboratory diagnosis, what we consider probable dengue and what we consider a confirmed dengue. So this case definition is given by the Ministry of Health and Welfare of India. A probable case of dengue fever or dengue hemorrhagic fever is considered when the case is compatible with the clinical description which I told earlier, or it is a non-ELISA based NS1 antigen or IgM positive. So if the RDT positive patient are considered only probable dengue. They are not considered a confirmed dengue. A confirmed dengue fever is only considered when we can isolate the bacteria in the culture from the serum or plasma, or we can demonstrate Ig antibody titer by ELISA, or we demonstrate a dengue virus antigen by NS1 ELISA, or there is a seroconversion of IgG after 2 weeks. 4-fold lies in the IgG titer, or we detect the RNA of the dengue virus by the PCR. So probable dengue is clinical criteria plus a rapid test positive, and confirmed dengue is when we have confirmatory evidence from the lab by ELISA, viral culture, or by the PCR, or there is a 4-fold lies in the serology of the dengue. Now, what are the factors determining these? So dengue fever, that it is shown that type 2 is more dangerous than other serotype. So if we are infected by type 2, then they can occur dengue hemorrhagic fever or sequence, as I have told earlier, the serotype 1 followed by serotype 2, or in children less than 12 years of age, dengue hemorrhagic fever or dengue shock syndrome is more common. Next, what is the effect of dengue in pregnancy? Perinatal transmission of dengue can occur, and the child can get infected by the dengue, and it can present with fever, thrombocytopenia, ascites, or pleural effusion at birth. Now, mostly I will discuss about the laboratory diagnosis. So how we can diagnose dengue. Diagnose can be detected either by direct method, which is virus isolation, genomic detection, and the antigen detection. and the indirect method, which include IgM serology and IgG serology. So the first test to become positive, they are the viral RT-PCR and the NS1 antigen, while serology get detected later on, and it depends if it is a primary infection or the secondary infection. So first, direct method, we can see the virus isolation. As we all know, if we are isolating the virus, it is must be the gold standard, because because it is the utmost test that we can do. So if we can isolate a virus, then it is considered the gold standard test, although it is very cumbersome and we need a very high laboratory for this. So virus can be isolated either in molecular cell lines, mosquito cell lines, or in the mammalian cell lines. Mosquito cell lines like AP61, TRA284, the most commonly used the C6 or C36. Whereas there's mammalian cell lines, the LAK, MC2, Viro, and BHK21 cell lines. LLCMK2 cell lines are the most commonly used cell lines for the virus isolation. Then sometimes we can also isolate by growing the virus in the mosquito. And the 4 species of the virus mosquito that I used are Aedes aegypti, Aedes albopictus, and Toxorhynchus amboniensis, and splendens. These are the 4 mosquito varieties in which we can inoculate the virus and get the virus from the inoculate the virus, and we can get the results. Second, the newer gold standard is the molecular diagnostic. It can be nucleic acid amplification based, like normal PCR, conventional PCR, or the RT-PCR. It can detect the virus in the blood and serum up to 5 days. Mostly it cannot detect after 5 days. The sensitivity goes to very low. It can detect very low amount of viral copies, like as low as 100 viral copies per ml. And the sensitivity of the current molecular tests or RT-PCR available are the 80 to 90% sensitive and 95% specific. A positive PCR is a definite proof of the current infection, but if it is negative, then we should interpret it as intermediate and send it for serological testing after 5 days of illness, when we can detect the IgMs. Now, after conventional PCR, we can also have real-time RC-PCR, which can also detect the viral load. And there are multiple types, like simplex and the multiplex. Multiplex can detect all 4 types of the serotypes in a single sample. And the gene that it used for detection is the viral RNA 3 UTR region gene. The FDA approved in the USA, the net that are FDA approved in USA are the CDC, Den-1-fold real-time RT-PCR multiplex assay, and the triplex RT-PCR assay. These are the assays that are used. Second molecular method is the isothermal amplification based test. There are 2 isothermal based amplification tests, like NASBA, nucleic acid sequence based amplification, and the RT-LAMP assay. These are known isothermal because they do not utilize the change in temperature for multiplication like in conventional PCR, but they do the multiplication at a constant temperature. So they can be also suitable for the epidemiological purpose in the field. Like NASBA is entirely isothermal process is done in the 41 degrees Celsius. Now, next comes the most important test that is utilized nowadays for the detection of the dengue. This is the N+1 antigen. It is detectable in the serum 1 day after the fever, and it is positive up to 18 days. It is a 55 kilodalton glycoprotein, which is synthesized by all flavivirus, but we can get a specific by using specific monoclonal antibodies, NH1 capture ELISA, we can detect the serotypes also. Now, the antibody detection. Antibody detection has some complexities because it can differ in primary and the secondary infection. In primary infection, IgM appears first after 5 days of the fever and disappears within 90 days. IgG is detectable in low titer in first 14 to 21 days, and then it slowly increases. So the primary infection, after the 5 days, we can get an IgM, and IgG after 2 weeks or 3 weeks we will get. But in secondary infection, IgG antibodies rises rapidly, and it also cross-reactive with many flavivirus. So we can, in secondary infection, diagnosis very difficult. This is a chart showing the viral load and the IgM and IgG in the primary infection and the secondary dengue infection. In primary infection, as you can see, the IgM rises rapidly after 5 days and remains positive up to 90 days. After 2 to 3 weeks, IgG starts to rise, and it can remain positive up lifelong. But in secondary dengue infection, you can see that IgM, before the IgM rise, there is an IgG rise, and it constantly rises and then it can be detectable up to lifetime. But the IgM is same, and sometimes it is not detectable also in secondary dengue infection. So what are the methods that are available for these antibodies? There are numerous methods. 8 important methods are the heme agglutination test, neutralization test, indirect immunofluorescent antibody test, ELISA test, complement fixation, dot plotting, Western blotting, and rapid immunoblot. IgM and IgG capture ELISA are the most commonly used tests nowadays used for the antibody detection. First is the heme agglutination test. It was very much utilized in the past, but has gained its importance in the recent times due to availability of the ELISA and the antigen detection tests. So I will not be going into a detail how the heme agglutination test works, but the titer of 1:1280 is a proof of the primary dengue infection. Whereas if the titer is less than this, then we can say that there is no dengue infection. Next is the most common and the most important serological test used is the MAC ELISA. MAC ELISA is known as IgM capture ELISA. IgM capture ELISA, which is the most important tool, and it has a sensitivity of around 90 to 98%. But only when used after the five days of onset of fever. Sometimes there is a mistake that we do as a clinician, that we order a IgM IgM ELISA test in 3rd or 4th day. So the sensitivity decreases. There are different formats available for these ELISA, they capture and ultra micro ELISA, dot ELISA, and others. So it is basically IgM capture ELISA format based on capturing human IgM antibodies on a micro titer plate using anti-human IgM antibodies followed by addition of dengue virus specific antigen. So we can detect the serotype specific also with the basis of this IgM capture ELISA, and it involves the envelope protein virus. Antigen involved is the envelope protein of the virus. Next is the IgG ELISA. IgG ELISA is only used to detect the past infection because it comes after 2 to 3 weeks and lacks the specificity as it may be increased in other flavivirus infections. However, we can detect primary versus secondary infection by using a simple algorithm like sample with IgG negative in acute phase and a positive IgG in convalescent phase. We will detect it as a primary dengue infection. Or if the sample is IgG positive in the acute phase and there is a four-fold rise in the IgG titer in the convalescent phase, it corresponds to a secondary dengue infection. However, it is not a very good test, and it is only used for surveillance or for diagnosing the past infections. Next is the IgG evidence test, which increases the IgG test uh, specificity in determining the secondary dengue infections or the primary dengue infection. Avidity means the property or strength of the formation of the bond, non-covalent bonds formed between the antigen antibodies. So if the avidity is more, then we can tell that the uh, dengue infection is a secondary dengue infection because it has developed a more prompt response of IgG. So IgG avidity index requires only a single sample of acute phase serum and used in the characterize the dengue infection. However, it is a complex test and is not readily accessible globally and in India. A more convenient test is the IgM-IgG ratio. The E or membrane protein specific IgG ratio can distinguish between the primary and the secondary dengue infection. IgM capture ELISA and IgG capture ELISA are used for this purpose, and that if the ratio of IgG or IgM is 1:2 is greater than 1.2 or 1.4 depending upon the dilution, if we are using 1/100 dilution of patient sera or by 20 dilution of the patient sera, then it is known as primary dengue infection, mean the IgM is more than the IgG. But if it is less than 1.2 or 1.4 depending upon the patient sera, then it is called as the secondary dengue infection. Sometimes we also use IgE capture ELISA for the diagnosis of dengue, but it has a very good specificity and the IgG peaks around day 8 and decreases rapidly and undetectable around the day 40. Even though IgA values are lower than IgM, both in serum and saliva, these IgA, IgG, IgM serology can be used combinedly to determine the dengue serology of primary and the secondary infection. These are the various kits nowadays, ELISA kits available for antigen and antibody detection we are using for the diagnosis of the dengue. Next important test is the plaque reduction and the neutralization test. It is the test that it is done in a micro neutralization plate, and it is the most specific serological test, even more specific than the ELISA. Then it is used to detect the infective serotype in the convalescent sera. This assay measures the titer of the neutralizing bodies in the serum of the infective individuals and determines the level of protective antibodies in the individuals towards the infected virus. So what is this test? We make a cell culture on the base of the microtiter plate. We allow the virus to infect and we pour the serial dilutions of the sera. If there is neutralizing antibodies present in the sera of the patient, they will be neutralizing the bacteria and there will be no growth of the bacteria or virus on the cell culture. And we can see that by like this, dilutions like this, and we can see this plaque reduction growth. So if there will be neutralization by the virus, by the antibody sera of the patient, there will be neutralization of the virus, then there will be no growth or no plaque formation. And we dilute the sera, then there will be the growth of the plaque. There will be plaque formation. So by this, we can determine what is the cutoff value or the titer of the antibodies present in the patient serum and against which serotype. Now, lastly, coming on the rapid diagnosis. So RDT kits are readily available nowadays. We can do that test at home or rapidly within 15-20 minutes. But there is a vast problem or there is a question mark on their sensitivity and specificity. Sometimes they get a very good result and there is a false positive rate are also high. So based on this, if rapid test come positive, then Ministry of Health Welfare has said that we will not take it as a confirmed dengue test, but we will give it a nomenclature of probable dengue because there is a poor sensitivity and specificity, and it will be confirmed by the ELISA. These positive tests should be confirmed by ELISA. So these were some of the studies I was looking. Recent studies like this was published in European Journal of Clinical Microbiology in August 22. So they after studying the meta-analysis and systemic review of various studies done on the rapid test, they conferred that the sensitivity of IgM concerning studies range from, there was a wide range, 13.8 to 90%, while NS1 ranged from 14.7 to 100%. Antibodies with NS1 presented with a better, so a combination of NS1 and IgM antibodies got a better sensitivity and specificity of 90 and 89%. Another studies that was published in Spain, that combination of NS1 antigen and IgM or IgG antibody rapid testing gave a better result than the individual IgM or NS1 or IgG antibody rapid testing. However, there are vast difference in the sensitivity and specificity. These are the various dengue rapid test kits available by various companies. Now, there are newer advances in this dengue diagnosis. There are studies are done on the nano diagnostic tools with nano-sized materials, including the liposomes, nanowires, nanopores, and the coupled with the conventional fluorescent and potentiometry to give the result. Further, I will not be going in this. They are the newer diagnostic tools that will be getting in the future. Some of the tests that are being developed are the microsphere-based immunoassays. Microarray technology is very in growth nowadays, and the biosensor technology using mass spectrometry. It has mass spectrometry has got a very good result in bacteriology. So now they are aiming it for use in the virology also. So one article I found which showed that these technologies are in development for getting better sensitivity and specificity in diagnosing dengue and other. There is the CRISPR approach, which is clustered regularly interspaced short palindromic repeats. It was also used, tests were developed for this against COVID virus, detecting COVID virus in COVID-19, and various other like surface plasmos resonance-based technology, electrochemical sensing-based technology. These are also in microfluid-based technology in development nowadays. Hope we can get a very specific and sensitive and user-friendly test from these technologies. Now we have discussed all these. So all the tests have some good points and bad points. So like virus isolation, it is very complex. It is to do, but it is very specific and identifies the serotypes. Then R&D detection. Now the rapid RT-PCR tests and the PCR tests are available. So we can give results in 24 to 48 hours. It is very specific, new gold standards, but it requires a very expensive laboratory, and there is time difference. Like we cannot detect by till 5 days. We cannot detect. There is NS1 antigen. It is very it gives NS1 antigen ELISA test is by doing, then we can get a confirmed infection result, easy to perform, less expensive than the molecular test is, but not as sensitive as the RNA isolation test, because viral load should be higher to detect these antigens in the blood. Then the serological tests have both their positive and the negative side that I was discussed earlier. Now, lastly, we should come on the treatment of the dengue. So, dengue hemorrhagic fever is self-limiting. Mostly 70 to 80% of dengue infection are subclinical or asymptomatic. Then from that, we get the dengue fever, the symptomatic dengue infections. That is also self-limiting. Only there is, if we replace the plasma or correct the electrolyte and metabolic balance, and we do, if the platelet count is less, very less, then we can do platelet infusion. WHO has given treatment protocol. According, it has divided in 3 management groups. All the dengue hemorrhagic fever or dengue fever patients, like group A, they can be managed effectively at home. So what are the group A patient management guidelines that we use oral fluid, paracetamol, and we should avoid the NSAIDs. NSAIDs are the ibuprofen, diclofenac. We should avoid these and only use paracetamol and oral fluid. And if patient belongs to group A, then we can treat with this. If there is group B, group A is dengue fever. Only clinical sign symptoms are present and very mild disease. Group B is there is some indication of severe disease like fever is continuing and there are no warning signs, then we can also use oral fluids. And if not tolerated, then we can use IV fluid for 24 to 48 hours. The IV fluid are normally recommended is 0.9% saline or the lingual lactate solution. And other clinical parameters like platelet count should be monitored. When the warning sign develops, and it is group B with warning signs. So when the warning sign develop, the hematocrit should be monitored by daily and there should be a specific isotonic fluid transfer, IV fluids like 5 to 7 ml per kg per hour for 1 to 2 hours and 3 to 5 ml per kg per hour, 2 to 4 hours or other, depending on how much the patient can tolerate. Then increases or decrease in the fluid rate should be based on the hematocrit management, and it should be done every 6 hours. Then there is group C. Group C falls in the severe dengue, very severe dengue, hemorrhagic fever, or severe dengue, that new classification that WHO has given. Then there should be a judicious fluid resuscitation, and the bleeding manifestation should be managed. There should be glycemic control and hemofluid, and the intravenous fluid should be discontinued when the hemodynamics gets stabilized. So there, as we can see, there is no specific antiviral drug for dengue. Only there is supportive management by antipyretics and the IV fluids. And the bleeding manifestation should be managed, and the platelet transfusion should be prompt if there is indication of the rising hematocrit. The WHO has given this chart full treatment guidelines. I will not be dealing in detail for all the guidelines. In short, I have told this. These are our management guidelines, national guidelines for clinical management of dengue fever for Government of India by the Government of India. Now, more than treating the dengue, it is better to prevent and control the dengue. So what are the basic requirements for controlling the dengue? The vector control measures we should utilize. Firstly, we should use that we should protect our families from the mosquito bite, wear protective clothing, and all using mosquito repellents, and keep the surroundings clean, avoiding the stagnant waters, and using mosquito repellents. So MHFW has given these points. We can use the personal prophylactic measures. Biological controls is very happening today. So use of live wishes in the ornamental tanks and fountains, and use of biocides. Then we can do chemical controls by spraying the insecticides or larvicides by doing the source reduction. So this is the most important in decreasing the dengue load, by properly covering the store waters and reliable water supply and observation of these areas and destroying them. That are the breeding places for the mosquito. Health education is very important, and the community participation is also very important. Now, the last resort for our prevention of dengue can be dengue vaccines. But since dengue has so many serotypes, like 4 are basically present, and the fifth, the discovery of the 5th dengue virus serotype has further increased in the problems in the development of the dengue vaccine. So these dengue vaccines are in pipeline. One of the dengue vaccine is in phase 4 trial. It is approved for FDA by the use in the humans, which comes in the brand name of Dengue. So what is this Dengue? It is licensed for human use from 2015, and it is chimeric yellow fever dengue vaccine, which is live attenuated. Chimeric means a dengue fever virus and yellow fever virus have been merged to form this vaccine. It is a tetravalent vaccine, and it is developed by Sanofi Pasteur. It utilizes live attenuated virus of 7D yellow fever vaccine as a vector, which contains the outer and the serotypes or the DNA or RNA of the dengue virus. It is indicated in 9 to 45 years of age. Their doses are 3.5 ml administered subcutaneously at 6 months. It is available in lyophilized form and reconstituted in normal saline to be given. There are various contraindications like allergic reaction, immunodeficient, pregnant female, and the efficacy for biological confirmed cases is 82%. Hospitalization is reduced by 79%, and severe diseases in 84%. But it is only recommended in high burden countries, which has a seroprevalence of more than 70% of dengue. And one more complication is that it should not be given in the patients or the persons who have been infected once by the dengue, because it can give rise to secondary dengue infection, and that can lead to disease, severe dengue disease. So currently, this vaccine is being given in Mexico, Philippines, Brazil, Indonesia, Thailand, and Singapore. These are the countries. India, it is not available, and it is not been licensed till now. So this was the prevention. The problem, why we have only one vaccine till now, because there are 4 serotypes of dengue, and dengue is a RNA virus which regularly mutates in comparison to the DNA viruses. So there is quite a lot of problem in developing dengue vaccine, but one we have gained a success, that is DengueVaxia. Hopefully it will be available in India also when the safety data permits. So this was a brief about overall how we can diagnose, what are the clinical features, and all about the dengue virus. I only tried to cover it shortly in a manner so all the participants are able to diagnose. And
Well,
so thank you.
thank you, Dr. Ahmed. Thank you very much. That was an extensive discussion on what do I say, a virus that we are all familiar with, you know, and dengue is something that I believe when you highlighted, you know, there was this geographical map that you showed of the country.
Yeah.
I believe that must be from NBBDCP, the source of the map. You know, but our experience has also shown that there's been a lot of change in that map over a period of time. And your subject was on public health, you know. So I had a question that, you know, you are a diagnostician and you see a lot of dengue happening all around you. Do you believe that, especially in countries such as India, which are in the tropical regions, one, global warming, second, rapid urbanization. So is this affecting the incidence of dengue in the country?
I've told the points that were leading to the rise of the dengue. They are mostly this urbanization, unplanned urbanization that is occurring in our country. The water resources.
But okay, the second part, what would be, in your understanding, the potential impact of climate change? Because we are seeing
climate change is also very affecting. I have seen that. I have told that Aedes mosquito, it is surviving a lot more, and they get suppressed in the lower climate or the global warming that is occurring. The larva and they are surviving more and better in these climatic conditions. And you can see the rainfall pattern that has also changed, very much changed.
Yes.
Sometimes there is very heavy rainfall, then there is a dry period, then there is very heavy rainfall. You can see this time in Uttarakhand, there is a very heavy epidemic going in Uttarakhand. Most of my relatives are in Uttarakhand, and they got infected by dengue.
Even now, sir? Even now,
yes,
doctor?
Yes, last month, my sister-in-law and other were there, and they are also microbiologists, pathologists, and all, and they got infected by dengue.
Okay.
And they were saying that they are seeing patient every fourth individual they are seeing with dengue fever. Although not everyone is getting dengue hemorrhagic fever or severe disease, but asymptomatic subclinical infection, they were in that time they were having heavy rainfall in Dehradun.
You know, I don't know if you've observed this, but I'd like your take on this. This is an odd year, let's say 23 or 21 or 19.
Yeah.
So there's a lot of discussion in lots of forums about odd and even year for incidence of dengue. I have never believed the mosquitoes follow odd and even. That's only for Delhi traffic, right?
Yeah.
But there is a lot of discussions that we hear in the when we meet doctors also. Oh, this is an even year. There will be no dengue this year.
Actually, we cannot support, because data is only the dengue that are reported cases. We can get the data only, but 80% of the cases are not reported in dengue. And the chart I showed in that chart was there on NCVDC that showed that 21 and 22 both had in lakhs, 25 lakhs and 22 lakhs
Correct.
cases
Correct.
of dengue.
Absolutely.
Then there was 20 was a lull
I
year
think
for
20
dengue.
was a year we all prefer to forget, and even dengue said, "Let me just avoid it." There's no, because people are too busy reporting COVID to talk about dengue. Honestly,
Yeah. Testing was also reduced. All sample were coming for COVID, and they were testing COVID. But I was posted in. I have done a project with ICMR on National COVID Registry. So I saw patients with COVID and dengue co-infections.
Oh,
Many cases. They were COVID and dengue. They were coming positive for dengue also, and they were platelet counts were falling very rapidly. I saw that patients.
yeah. I mean, we are on the
But
other
they
side
were,
of the fence, so we saw that people were not keen to report dengue. They were not keen to test for
yeah,
dengue. It
yeah,
was easier to test for COVID, and if you had fever, it was safer to stay at home. Nobody wanted to come out and take a risk.
yes,
Actually.
yeah.
So, but where do you foresee next year? I mean, going forward, global warming and urbanization as two factors are not going to reduce. So, do you see an increase over a period of time for dengue, or do we see us,
Yeah.
going past that curve?
I think dengue cases are on increase. Mosquitoes are on increase. Our control measures are not that effective on mosquito till date. So basically, we should aim in control measures are the basic requirement, but we should also aim in better diagnosing the dengue.
Because PCR is
Better
still
and
not
rapid diagnosis
affordable.
of the.
I've seen PCR,
Yeah,
it's still not affordable. So, what is your
PCR,
take as a
even ELISA,
diagnostic?
ELISA, even ELISA, everybody cannot afford. Rapid testing should
Absolutely.
be done.
So,
Rapid
my
testing
thought was
should
this,
be.
Dr. Ahmed. What if there was a home test available? Like COVID, there was a home test available.
Yeah,
So similarly for dengue NS1, not for IgM, because IgM is open to multiple diagnosis. But if
yeah.
for home, especially for NS1, if we had a home test,
Hmm.
what do you think would be the mindset of the treating physicians? Because essentially this is taking work away from them and putting it power in the hands of the user, democratization of testing, right?
Everything depends on the persons or the people. Like we can give like a gun, it can also protect, it can also kill. So similar is the self-diagnostic test. If it is done properly by, if the patient doing is well educated, well, if not well educated, our population not that well educated, but it is doing that, it is following the instruction properly and doing that test properly, then that test and should be considered, and it will help us solve very much problem. Like most of the, I saw 2 3 patients, they were from low socioeconomic group, so they've been having fever for about 7 to 8 days. And when they told me, I told them to do a platelet test or CBC, and their platelet count was, one was 15% and one was 15,000, one was 25,000. So they are afraid to go to a doctor, or they cannot afford it, and they um, sitting at home with so much less platelet count. If we have a self test and it can diagnose properly dengue test, dengue, then they can consult the doctor more. If they've got positive, then they can consult the doctor and a confirmatory test can be done. But for screening, we can use that self-test, and educated people should start first and non-educated
I
should.
always like to say my gurus are the doctors. So
Yeah.
Govind, what you're going to do now, since you've had this discussion, uh, Dr. Ahmed, we have launched the home test recently. That's why I asked you this
Okay.
question. And while
Okay.
it's available at a few places right now, because the prevalence of dengue is coming down and awareness level is also not too high on home testing.
Yeah.
So we'll send you a couple of home tests. Right? It's a simple test. It's actually very simple to do. One drop of blood and that's it. Nothing more.
Okay.
Okay, it's as simple as that. So we have catered to the lowest common denominator in the
Okay.
testing market.
Yeah.
We'll send
The
you a
simpler
couple
it
of those,
will
and
be
we'd
better
like your
to use.
opinion. Nothing more. We'd like your opinion if this is user friendly and easy to do. Right?
Okay.
Perfect.
So yeah, I can do a pilot study.
Absolutely. We would love to do that, sir.
We
Mr.
can
Bharadwaj will
test.
be in touch with you.
Okay. We can
Govind will
test
be
in
in
on
touch
some
with you.
patient.
Yeah.
We can test in on staff also. Our staff, so they can do that home test if they are feeling fever or they are having something. Or we can do like, if we have diagnosed someone positive, and we can give that test kit, and we can call it back and see that if he has also come positive that with that self kit, and we can compare negative and all that, because it controls negative controls. We can do a study, or we can do this home test, and
I think the home
ease of
test is
use.
due for a study now. Everything else is approved by the government, but it would be a good,
No, only a small 5 to 10, 50,
absolutely,
15, 20
absolutely. We are very
patients.
open to that. But again, that's another point for another discussion for another time, right?
Okay.
Thank you
Yeah.
so much for your time and your effort, Dr. Saab. And
Okay.
allow me to present a small certificate of appreciation. We'll send the framed one to you directly in person. So
Thank
Govind
you
will
so much.
facilitate that. But for now, thank you for your time. And from our end, a very warm and grateful JMitra. Thank you.
Thank you.
Thank you, sir. Thank you all for joining us today. Our next webinar will be towards the end of the month, and we'll be taking up the subject of malaria diagnosis. Thank you all and have a great day. Jai Hind.